Good afternoon, everyone. Let me introduce you my project, The Impact of Timely Care in Pancreatic Cancer. My name is Noémi Németh, and I work as a gastroenterologist resident at the Division for Pancreatic Disorders at Semmelweis University. My vision is to improve the prognosis of pancreatic cancer by developing the best diagnostical pathway for patients to ensure the longest possible survival and the best quality of life for them. My main goal is to understand the effect of lag time on the prognosis of pancreatic cancer by doing two types of studies. The first one is a meta-analysis and a systematic review as the effect investigation of lag time between the start of diagnostic procedure and treatment of pancreatic cancer. We analyze the already existing data on the topic. Secondly, we establish a pancreas solid tumor registry to conduct more data and do a specific analysis on the topic. So let's start with my meta. Pancreatic cancer is the seventh leading cause of cancer-related deaths worldwide, with a significantly increasing incidence and an extremely low 5-year survival rate, 5 to 10% on average. However, if the lesion is resectable, this number can reach up to 30%, as the only known curative treatment of the disease is surgery. In current practice, the general lag time can take up to 50 days, sometimes even more, and this diagnostical delay might strongly affect the survival rates of these patients, as pancreatic cancer is a rapidly progressing disease. Our aim was to investigate if time periods from the start of diagnostic procedure to therapy initiation influences long-term outcomes of pancreatic cancer patients. To answer this question, we used the general PICO framework, where population was patients with pancreatic cancer, and we compared different time intervals from the start of diagnostic procedure to therapy. The primary outcomes were overall survival and resectability. We hypothesized that by decreasing the time of diagnostic management, we can prolong pancreatic cancer patients' life. The systematic search was conducted in 3 databases, and originally we got more than 21,000 articles. After the selection, we found 17 articles eligible for meta-analysis and an additional 7 for the systematic review. And now, let me show you 2 preliminary results of our analysis. As the outcome is overall survival, the results are in hazard ratio, where a value over 1 means decreased overall survival. The first intervention analyzed was diagnosis to treatment interval at a 4-week threshold. We compared 2 groups below and over 4 weeks. As you can see, the population is very heterogeneous. There were also resectable and unresectable cases included, and the heterogeneity is high regarding the treatment applied as well. As you can see, the hazard ratio is approximately 1. There were no significant differences, and I would like to bring to your attention that even in the resectable cases, where we would expect a better prognosis, there was no significant difference. The other factor analyzed was symptom to diagnosis time interval at the same 4-week threshold. We compared 2 groups below and over 4 weeks. The hazard ratio is 0.98, what also supports the idea that 4 weeks is way too long in the care of pancreatic cancer patients. And we have to educate our patients to visit a specialist, and we have to make sure that we provide the shortest possible care for them. Our study obviously had strengths and limitations. This is the first meta-analysis in the topic. We managed to conduct several subgroup analyses based on different time intervals, but it also has its limitations. The included studies are mostly retrospective cohort studies. The heterogeneity regarding the population and the time interval definitions were high. We can conclude that in the care of pancreatic cancer patients, 4 weeks is beyond the time when we can make a difference. It's too late to diagnose and too late to treat. As I mentioned it before, we conducted several subgroup analyses, so if we find the right time interval, it could restructure the guidelines for the diagnosis of pancreatic cancer. And another important aspect that we have to raise awareness about the alarming symptoms among the patients, but it's in our hands to provide them an early care and make sure that they have a quick access to medical care when they need it. In the topic, we would need more prospective studies, and we would also need to conduct research on the screening methods, and it would be important to find new biomarkers for the early detection of pancreatic cancer. That's why we established the registry of pancreatic solid tumors. It could give us more insight about the strategies of early diagnosis. We could find the population eligible for screening in the disease, and it could give us a better overview on the multidisciplinary approach of the disease. And we would also like to evaluate the new strategy, 4% strategy applied in our ward. And let me talk about this shortly. The main point of the strategy that 4 days after the first detection of the patient, he has a concrete diagnosis. We hold a council twice a week. This is the so-called MDT, multidisciplinary team meeting, where representatives of various specialties such as surgeons, oncologists, pathologists, gastroenterologists meet and overview the images, CT or MR images of the patient, and make a decision about further diagnostical procedures if needed. The second time we discuss the patient's case, we bring back the histological results and decide on the therapeutical approaches. This means that 7 days after the first detection of the patient, he can start the appropriate therapy. We collect patients' data in the O form until the pancreatic cancer diagnosis is confirmed. As the diagnosis is confirmed, we continue data collection in the A form, what is an advanced form of the O form. It has several additional data sheets depending on the time of diagnostical procedure or intervention the patients need. As we find follow-up essential, so we also have a follow-up form as well. This is the B form. And we hope to collect high-quality data and evaluate time intervals as well. Right now, the questionnaires are sent out for international experts to get their opinion, but also pilot patient enrollment started in our ward. I would like to close my presentation with the words of Michael Altschuler. The bad news is time flies. The good news is you are the pilot.
Congratulations on the presentation. The question would be, you haven't really found significance in the first project, if I remember correctly. So are you still looking at data extraction, any other further statistical analysis coming out from the data, or is that it?
Yeah, sure. We conducted, this is just like 2 of these subgroups we analyzed, we conducted several other subgroups, even time intervals for 2 weeks, 1 week, and we hope to see significant results there.
Thank you. So it's still at the statistician.
Yeah, still at the
Thank you.
statistician.
Yes, congratulations on the presentation. The second one is that you have to be very careful, I think, in the interpretation, because I'm assuming that these cannot be randomized control studies, but these are rather observational. So suggesting that, of course, they are astounding results. So it's very surprising for me that before 4 weeks and after 4 weeks, there was no significant difference. But you have to keep in mind that there will probably also be risk of bias. As you showed us, there is quite some difference between the studies that you pooled. So at best, I think very low certainty of evidence will be at the end of the line for this below 4 weeks after 4 weeks comparison. And the third comment, of course, is to what Olgi also asked, to see what happens before 2 weeks and after 2 weeks, because if you get same or similar results, do you think it would be realistic to further reduce the time from diagnosis to treatment? Because it seems that below 2 weeks, it's hard. It's very hard.
Yeah, thank you for the comments and the question. Actually, we have managed to reduce the diagnostical pathway below 2 weeks in practice as well. Not in every case, but we are working on it that it will be possible for every patient. Yes, we are still waiting for the statistical results, and we can conclude more after we have seen that.
If you don't mind, I've got a comment, and that's me. Hello. I've got a comment and a question. A comment is that I would try to draw your attention that there's a very heterogeneous population, which you showed in the first one, but don't forget it, the country is very heterogeneous, the place where it was taken, meaning hospitals, university, and so maybe it could be a very important data later on. The question is that why is 4 and 7? So we've got a lot of heating debated with Professor Hegyi. So this question is for you, Peter. So, but why is 4 and 7? Why not 5 and 6 or any other numbers? One question. And do you know any center in Europe or everywhere in the world which really works, which could be managed these 4 and 7 days?
As I mentioned it before, with the cooperation of our great colleagues and yeah, we managed to reach this 4/7 goal in here, Budapest, in the Szabadmányos University as well. And if I know it right, in the Netherlands, it's also a goal to reach this 4/7 strategy, and Professor Hegyi will add some other comments as well.
Yes, the answer is very easy. We don't know why 4 and 7. We try to make it as short as we can. We know that, for example, in Alicante, we had the word at the conference with George, Christian, they do it within 2-3 days to take the samples. So what we put, like in every study, if I have a proof of concept idea, and the proof of concept here that as short as the time, as high as the chance for survival, this is the hypothesis. And whenever we also try a drug and we do a phase 2 trial, we always try to look at the highest effect. Therefore, if we do within 2 weeks, and we can't see or we can see, it still doesn't say that which could be the best effect. So we believe that we cannot be shorter than this. As you see, we may not reach this, for sure. Maybe the average will be 5 days and 9 days, but to make a proof of concepts a study, this is how the lowest value we believed it could be in some cases at least feasible.
Okay.
But you are right, we don't know why not 6. Maybe 6 is better.
We should try it. So the other
everybody hear that.
I mentioned to you there's the big difference between countries. So Netherlands is not Hungary and Hungary is not Netherlands yet.
Sorry, but the pancreatic cancer patients, we are at international level already because they have the same disease.